Ellos son Imaya Canexia Health. Es una empresa canadiense que usa los últimos avances de la oncología y la inteligencia artificial, proporcionando a los profesionales en oncología la información necesaria para tomar decisiones muy bien informadas. Imaya Canexia Health está haciendo que las pruebas genómicas de alta especialidad en cáncer sean accesibles, y esto a través de una solución integral que aprovecha la bioinformática basada en inteligencia artificial, así como los datos clínicos y genómicos de los pacientes, para permitir que los oncólogos puedan tomar decisiones que sean más efectivas en cuanto a la selección de tratamientos dirigidos. Entonces, Anna, can you start with your presentation, please?
Thank you. It's a pleasure to be speaking in such a for such a great audience today. I see you have a lot of interested people joining the workshop today, so it's our pleasure. I will let Vincent to start our presentation. Vincent, if you can unmute yourself. Yeah, let's just give him a few seconds. Yeah, yep. We can hear you, I think.
Yeah. So just as a brief introduction, and then I think Brenda's going to go through the slide deck, but just as a brief introduction, so ICH, or Imaya Canexia Health, is a diagnostics company in cancer. We're looking to work with partners in order to work towards more of a democratized healthcare with health equity in mind for the same kind of treatment a patient would get using a large commercial provider now can get at their own hospital. We think this is really important, and we're trying to work towards this effort. So I'll stop there. Anna?
Thank you, Vincent. Yeah, so that was a great introduction. I'll just say that today we have actually several aspects to cover for you, and therefore we have a team of people from Canexia who will be speaking. So Vincent is our Chief Science Officer. You just heard his introduction. My name is Anna. I am an Alliance Manager, and I actually oversee our partnership with Laboratorios Rosalind. Stas Volek here is our scientific content person, so he will speak about the technology. And Brenda is our clinical molecular geneticist, who actually is responsible for generating clinical reports for oncologists, for their patients. And so we will all be speaking to slightly different aspects of our talk. So in the first part of the presentation, we will talk about why testing of multiple genes is important in oncology, and about the tools that are currently available in your local Laboratorios Rosalind. And then in the second half of the presentation, we will dive deeper into the basics of molecular testing in oncology and technology behind it, as well as we will highlight utility of the liquid biopsy as a relatively newer testing modality relative to the golden standard tissue testing. So before we move on with the presentation, I would like to bring up this glossary slide. We will be using certain terms that not necessarily everyone is using these terms on a daily basis. And so I just would like to remind everyone so that we are on the same page of what these terms are that we will be using. So somatic mutations is basically, we all know what that is. It's an alteration in DNA that occurs after conception and is not inherited. So it takes place in somatic tissue cells and can cause or be associated with disease. So mutations in those DNA, in that DNA, is something that we will be talking about. And there is different types of aberrations or mutations, if you will, that can take place during oncogenesis. SNVs is a single nucleotide variants. Indels stand for insertions or deletions. CNV is a copy number variance or a copy number change of the entire gene region. And MSI is the mark of satellite instability. So these are different types of aberrations that currently are considered in the in testing and treatment. VAS that we will be using is a variant allele frequency or percent of mutant allele in overall DNA sample. Liquid biopsy that we will be spending a bit more time during the presentation is a test that is done on a sample of blood from a cancer patient to look for cancer cells from a tumor that are circulating in the blood. So that could be CTCs or circulating tumor cells, or for pieces of DNA from tumor cells that are in the also circulating in the blood, and that is called ctDNA or circulating tumor DNA. So cfDNA is slightly different from the ctDNA, and that is a cell-free DNA. We'll also be talking about that very briefly, which is a mixture of a ctDNA coming from tumor cells and normal or benign DNA pieces originating from the normal dying cells undergoing apoptosis or benign cells. Term FFPE is probably very well known to you. This is the formalin-fixed paraffin embedded tissue that is a very standard type of the archiving of a surgical material. NGS is next generation sequencing, and ddPCR is a droplet digital PCR. So these are just the same things that I'm sure everyone knows, but just in case, so that we're on the same page. So why test for somatic mutations? So historically, single gene testing has been used in clinical oncology, and it was indeed everything that was needed for certain cases, such as CML or chronic myeloid leukemia, where majority of patients bear Philadelphia chromosome aberration involving a fusion gene BCR-ABL. And so this is just one example, but basically single gene testing has been a standard testing modality because it provided very quick turnaround and very simple interpretation. However, with time, it became very clear that cancer is a multi-gene disease. And moreover, the prevalence of certain gene mutations in cancer patient populations is quite limited. It can vary from, over 50% to just a few percent in cancer patient populations. And so although indeed single gene testing provides certain advantages, it certainly presents a disadvantage for cancer testing because of obvious limitations. It takes way longer to test for multiple genes at single genes at a time, one by one, and also it depletes the tissue that is available, and also delays the treatment decision making. So that's where multiple gene testing comes into play, and it's becoming pretty much standard of care in personalized oncology, and it does provide a lot of advantages. But bottom line, it provides efficiently provides information in a very timely manner on multiple gene mutations, and therefore decreasing the time when the treatment can actually start for the patient. So for many solid cancer types, the requirement by NCCN and FDA and other regulatory bodies to test for multiple gene mutations is becoming a reality. So for example, in the non-small cell lung cancer, this is a screenshot and excerpt from the NCCN guidelines available publicly, saying that the broad panel-based testing is strongly advised in appropriate patients with stage 4 non-small cell lung cancer, because it's more efficient than testing for one biomarker at a time. And below, you can see the list of the genes that should be tested for any aberration in order to make a proper treatment decision in this cancer type. And you can see that there is quite a few of established biomarkers, and more are continuing to emerge, such as ERBB2 and KRAS genes. So as treating oncologists are very well aware of, the number of targeted therapies is growing every year. And this graph from IQVIA, Institute of Health Data Science, is showing us here a tremendous growth over time from the early 2000s to nowadays of the number of oncology medicines available in the field with required or recommended predictive biomarker testing. So it's an incredible increase. And this slide shows a similar trend for clinical trials too, as one may expect. So here you see the number of trials that require biomarker testing, and the same trend actually is observed for the immuno-oncology focused trials specifically. So an access to such a testing capability may not be as easy in all of the regions worldwide. It depends. And so we at Connexia Health have established a partnership with Laboratorios Rosalind, where we empowered our partners with a personalized oncology testing capability. So now Laboratorios Rosalind owns our technology and is making it available to local oncologists. And so now I would like to talk a little bit more about that so that you know what tools are available to local oncologists through Laboratorios Rosalind. So a little bit more about us. So Imagine Connexia Health is a Canada-based biotech company that was established in about 10 years ago. So we run a laboratory based on the NGS technology, which is CLIA, CAP, and DAP certified. DAP is our local certification body. We also hold CE-IVD and Health Canada marks for our bioinformatics or computational part of our services. The ICH mission is basically, as Vincent alluded to, is to make precision oncology testing available to all patients regarding of their location. So what we do, we develop laboratory developed tests, and we bring them to local laboratories, such as Laboratorios Rosalind. We have distributed our molecular test technologies already throughout the world, including Canada, USA, Australia, South America, and Asia Pacific, where we have similar partnerships with local laboratories who run our technology in-house and make it available to their local oncologist communities. So up until now, we have collectively with our partners have helped more than 20,000 patients now who have received molecular testing using our technology for more effective therapy choice. So we have now 3 available tests that are available through the Laboratory of Rosalind. So we have 2 tests that are designed for tissue. These are called Find It on the left and Fusions. And we have a test called Follow It, which is designed for liquid biopsy testing. So Find It is an FFP, it requires FFPE samples and DNA extracted from FFPE tissue or any other archival material. It can be from frozen as well. So, and all of Find It, as well as other panels that we have developed, are actually quite focused. So we include into our panels only actionable content, meaning that we don't include, hundreds of genes, but we include only those that actually are important for treatment management for patients associated with certain targeted therapies, or maybe associated with prediction, so predictive biomarkers. Sometimes these could be diagnostic markers as well to nail down a specific diagnosis. So Find It, as I said, is a tissue-based test that covers 37 genes, and we detect 4 different types of aberrations within these genes, including SNVs, indels, CNVs, and MSI. As I mentioned, this is exclusively actionable hotspot mutations content on our panel. And so our limit of detection is 1% variant allele frequency. We have another test for tissue that detects fusions specifically. It's called Fusion. And so it is designed for FFPE samples where we detect fusions using RNA isolated from those FFPE samples. So this panel includes 18 driver genes. However, so all of these 18 driver genes are have known actionability, so they are linked to certain targeted therapy. However, we do not limit this assay to specific partners of these driver genes. So as you may know, fusions in fusion transcripts, it's important to know the driver component of the fusion, the driver partner. And so our assay is a partner agnostic. So we can detect known and novel fusions involving these 18 driver genes. The plasma-based liquid biopsy test, Follow It, has a matching panel, gene panel, to Find It. So it actually can be used together with Find It, but in plasma of patients. And it has the same content as I mentioned. However, the LOD, the lower limit of detection for plasma testing in this case is 0.4% variant allele frequency. So I'm just going to show this very quickly to you, and this is a gene content for Follow It and Find It panels. Our partners at Laboratorios Rosalind will have more information about this through flyers and other materials. So please ask for those materials. But this is just for you to see what kind of genes we include into our panel. And as you can see, all of the usual suspects, all of the important genes in major solid tumors are all included in here. So just to emphasize again, I think I failed to mention right from the beginning that our panels are designed for solid cancers, adult cancers only. So we do not cover blood cancers or pediatric cancers, which require significantly different gene set to be tested. So this is another slide showing the fusion panel content with 18 genes. And here, as you can see, this is basically a list of actionable genes here that are included into the FDA approved drugs and also part of many clinical trials. So only actionable mutation we have on our panels. So this is an example of actionable information that is available from our Find It and Follow It tests. And here just a few examples for breast cancer, colorectal cancer, and lung cancer, non-small cell lung cancer. As you can see, all of the major players in each individual cancer types associated with a specific targeted treatment can be informed by our panel tests. All our tests that we develop are very thoroughly validated using analytical validation and clinical validation using real clinical samples. And we follow very strict procedures for validation. We follow guidelines that are internationally accepted and published by CAP and CLIA, and also including our local accreditation body, DAB. So we follow these guidelines specifically for NGS tests. And so in this case, I'm just showing you very briefly what sort of clinical validation we have performed for each of these tests. And as you can see, we're covering multiple solid cancer types within our validation cohorts with good representation of clinical samples. And we use orthogonal data from similar technology or different technology depending on what is available. So we pay extra attention to the quality of our assays, and we make sure that the performance of our assays is top notch. And so here's, you can see information about the assay performance for each of these. And as you can see, the sensitivity, specificity, and negative predictive value and PV are actually quite good for all of these tests. So, and again, more information is available from the Laboratorios Rosalind, so please inquire. The ultimate product, the ultimate outcome from our panel tests is a clinical report that will be available for oncologists. And we have put a lot of effort into designing our clinical reports so that they are short enough, but with all of the important information available to oncologists right on the first page. And at the same time, they address all of the quality metrics that are associated with a specific sample. So everything that is required by CAP and ASCO with regard to the quality of next generation sequencing tests, we include this all into the report should an oncologist be willing to check out what was the quality of testing. So, but at the same time, we realize that what's important for oncologists is to be able to see the information that will help them with a patient treatment management. And so on our reports, we include all information that is necessary, on-label, off-label treatment options that might be useful for this particular patient with those specific mutations. Also, we provide a list of relevant clinical trials that may be useful for the patient. We provide mutation interpretation narrative, which explains the meaning of the mutation X in cancer type Y. We also pay extra attention to resistant mutations, should there be any mutations like that detected in the patient sample, such as T790M mutation in EGFR, which is a very well-known resistance mutation. And so we also provide information about that. And also, these reports are actually, you know, they can also contain all other information necessary for treatment decisions based on the context of the patient demographics and medical history. But that is basically done by the laboratory and the clinical geneticist who reports out this case. And all information from the pathology report or any other additional information available on the patient can be put on this report and made available to oncologists. So this is very briefly of what you have as an options in terms of the personalized oncology at your local laboratory. And so to order this test, it's basically very simple. You just place an order through Laboratorios Rosalind. And again, please inquire on the logistics around that from our partners at the Lab Rosalind. And then essentially, you receive a clinical report with mutations and interpretations. The average turnaround time for now is going to be 20 days. However, we are working with our partners at Lab Rosalind to make it less. So it actually, with time, it will be less than 20 days and quite significantly so. And so, as I mentioned, the first thing for us to make sure is that the testing is a high quality. And so this is our standards, and this is what we stand by. So now that we have reviewed the available tools for precision oncology that you can have and easy access to, I will invite my colleague Stas to dive deeper into how somatic mutations can be detected and what technology is behind it. Stas?
Yes, hello everyone. I will be providing really 60,000 feet overview of the technical issues and technical methodologies of mutation testing due to the limits of time. Next slide, please. So next slide. Yes, thank you. So the first question that needs to be addressed when we are thinking about testing tumor for mutations is where do we get the tumor DNA from? Literally for 1100 years, ever since the court physician to the Caliph of Andalusia, Al-Hakim II, wrote about using needles to ascertain the clinical subtype of neck tumors that were prevalent at that time. The answer was very obvious. If you want to study tumor DNA, you get a piece of tumor. And you know better than I that there are different ways of getting. You can get it either from excised tumor, like from after radical prostatectomy. One can use needle biopsies, and this approach has definitely a lot of advantages. If the tumor sample is reviewed by an expert pathologist who can mark the tumor boundaries, the resulting tumor sample will contain a very high proportion of cancer cells. Therefore, there will be a high abundance of tumor DNA relative to normal DNA, which clearly facilitates the detection of the tumor-specific mutations. And second, since again, this is the golden standard, the tissue is always already available in the tumor banks. However, there are obvious challenges also associated with this approach. First and foremost, tissue biopsy may not be always possible or practical. It is, for example, notoriously difficult to obtain the bone metastasis samples from the patients with advanced prostate cancer because the procedure is painful, difficult, and doesn't provide any clinical advantages at this point for the downstream clinical interventions. FFPE process through which the samples go through negatively impacts quality of DNA, and that introduces certain problems and certain artifacts which have to be dealt with when you analyze the results of the DNA analysis. Obviously, the sample is finite because the sampling cannot be done very often due to its invasiveness. So if multiple tests need to be run, there is a risk of running out of the finite sample from a given patient. And last but not least, some cancers, as we know, are very heterogeneous, and the sampling of the tissue is limited to the site where the original tissue sample was taken from. So other clones may be left undiscovered and unprobed, with sometimes disastrous consequences for a patient. Next slide, please. Another alternative source of the tumor DNA proved to be actually blood of the tumor patients. Ever since 1948, it was known that there is DNA in the blood of the animals. And this DNA can come from dying cells in the organism. Since we know that there are always cells that are unhappy, dying for various reasons in the organism, they rupture and they release the DNA into the bloodstream. And in the tumor patient, the tumor cells will behave similarly. So the circulating cell-free or cfDNA in tumor patients will consist of will come from two sources, from the tumor tissue and from the benign tissue. There's a third source of possible source of tumor DNA in the bloodstream. This is circulating tumor cells, and this can be seen, can be looked at as very advantageous source because this, if isolated, they offer access to the pure cancer DNA. However, there are very few cells, so the amount of DNA available is very, very low. One cell contains about 6 picograms of DNA. There are, say, about 10 or 20 circulating tumor cells on average found in the very high burden metastatic disease patients. So that means that 1 milliliter of patient DNA may yield about 100 picograms of DNA, which is very, very low number. It's about 1,000 times less than can be obtained from the circulating tumor DNA. Now, if we look at the specific advantages and challenges of using ctDNA for testing, we can, there are as follows. First of all, ctDNA offers usually integral representation of tumor heterogeneity. All sites, or most of the sites, tumor sites in the body undergo cell death at certain rates. So all of them release ctDNA into bloodstream and can be detected. Clearly, blood sampling is minimally invasive and very easy to carry out. And as I mentioned, there are large amounts of DNA available when we compare to CTCs. However, this does come with its own challenges. First of all, the abundance of tumor DNA in the bloodstream is actually quite low, because clearly there are way more benign cells in the patient's body than there are tumor cells. And this requires sophisticated experiment design and sophisticated data processing of the obtained data. You can miss mutations from the cancer cells that, or cancer sites that do not shed or shed little DNA. This is, in principle, it's possible. And finally, the results can be confounded by the somatic mutations identified in the blood cells, because they also can carry sometimes mutations similar to the tumor ones, and it's difficult to separate ones. Next slide, please. So to summarize, we have two possible sources of the DNA from tissue and liquid biopsy. And if we compare the advantages and challenges for each of the sources, we can see that clearly they are very complementary synergistic approaches. So they can be used in tandem to the great advantage. So now, next slide, please. So let's talk about the technical methodologies which are used for analysis of the tumor DNA samples. There are actually two types of technologies that are available for analysis of mutations in tumors. Type 1, as I would call it, targets specific changes, mostly point mutations, such as SNVs or single nucleotide variants, the substitutions of the nucleotide bases in DNA, and short indels. The prime example of such type of technologies is droplet digital PCR or ddPCR. The another type of the approaches can assess all or most of the possible aberrations. That includes point mutations, indels, copy number variations, you name it, in genomic regions of various length. Predominantly, currently, these technologies are based on the next generation sequencing. Next slide, please. So let's look a bit closer at the technology that allows one to analyze a few specific mutations. The first question that comes to mind is, why would you want to use such a technology? Because it's clearly very limited when you can target only 1 or 3 or 4 or limited number. And the answer is that these approaches allow incredible sensitivity and specificity of analysis. If your goal is to detect 1 mutant DNA fragment out of 100,000 to 150,000, this is the game. But it comes at the high cost. And the reason for it is purely technical, because what underlies this whole complex procedure is designing specific robust PCR assay for each of the sites that you want to target. These assays have to be first optimized separately, then have to be optimized together if you want to multiplex them. And if you want to expand this assay, you have to go through the re-optimization process again. And thus, this very high sensitivity and specificity comes with the cost of a low flexibility and difficulty to expand. And of course, as a corollary, another problem for using this type of assays, because of the inflexibility and low multiplexing ability, is that they're not really very suitable for the cancers that lack high-frequency driver point mutations. And so that limits, again, their usability. Next slide, please. So another type of technologies, once again, this nowadays, these are mostly NGS-based. We'll be talking in a little bit more detail now, because that's what Connexia is offering. So NGS stands for next generation sequencing, and the idea is, again, very simple. If you want to learn to compare the cancer DNA to the normal DNA, you just sequence the cancer DNA. How is it done practically? So there are 4 stages for such an analysis. The first stage, one collects the sample from which the DNA will be isolated, and isolates DNA. Again, this can be a tumor sample, it can be a plasma sample, it can be whole blood, depends on the design of the assay. As the second step after DNA was isolated, it is shared, size selected. There are certain steps that prepare DNA for sequencing. Importantly, there is an enrichment step where you pull down using these bioattenuated DNA probes that you can see in the B panel to pull down the regions, to enrich the regions that you are interested in studying. And these bioattenuated probes are, again, not as simple as they look. A lot of sophisticated science gets into designing these probes. And finally, the target enriched DNA is sequenced on the sequencing machine. After that comes the next stage. The DNA, the cancer DNA sequence is obtained, is compared to the normal reference genome, and data analysis pipeline allows one to, again, identify all known types of aberrations for the regions that you have targeted in your original design. And last but not least, and extremely important, I should underline, is the report generation, whereby you have to filter out polymorphisms that can be found in normal human population, but can also be found in cancer cells and can even be somatic. You can, so then you explore the publicly available clinical databases to establish the clinical relevance of the findings. You do the curation, and finally you generate report and recommendations. And this is, again, a sophisticated, involved pipeline that does all of it. Next slide, please. Next slide, please. Right. Okay, we are here. Okay, so to summarize, next generation sequencing technology allows for sampling of all known types of cancer genetic changes. It has very high multiplexing potential, and therefore it is very suitable for cancers without high frequency driver mutations. It's inexpensive and it's relatively easily extensible due to its design. Obviously, there are some costs associated with these advantages. It provides somewhat lower sensitivity and specificity than technologies such as ddPCR. Therefore, sophisticated bioinformatic approaches are required to both design the primers or the enriching, primers and the enriching probes that I was talking about. And it produces large amounts of data. that has to have to be stored, analyzed, transferred, and that's also, and all this has to be done securely. That's also a challenge. Now, next slide, please. So this concludes the, as I said, 60,000 feet overview of technology. And in the last chapter of our webinar, we'll talk specifically about liquid biopsy, which I mentioned, and this is relatively recent and not as widely used. So let me invite my colleague Brenda, our molecular geneticist, to speak about it.
Great. Thank you, Stas and Anna, for setting the stage. We're now just going to move into liquid biopsy applications. So I really want everyone to understand it's taken us 75 years to get basically to where we are today. And it is based on what we've heard. It's that sensitivity, the ability to find those very small amounts in that plasma DNA and then be able to interpret it. So, you know, back 75 years ago, we saw the presence of DNA in plasma. We then started seeing the cfDNA, and we could see that it was in metastatic cancer. In the 1970s, we're seeing that half of cancer patients, we could see a correlation that they seem to have a higher volume of cfDNA. In the late 80s, huge development, finding that females that were pregnant with male fetuses, we could actually detect the Y chromosome. And this just exploded into prenatal diagnosis recently as well. In 1994, again, looking particularly at AML cancer patients and looking specifically at RAS mutations, and not only just point mutations like single nucleotide variants, but very specific cancer signatures, such as loss of heterozygosity and hypermethylation. So getting the ability to get in there and see these things has just been immense. But 21 years ago, it was really a very important discovery, looking at the cfDNA, looking at the ctDNA, and actually trying to figure out, do we have the sensitivity to move forward? And roughly we're seeing, depending on the type of cancer, depending on the stage of cancer, 3 to 93% actually have that ctDNA in there. So this DNA, we move to the next slide, there's many applications in medicine. And this degraded DNA that is released into the blood plasma, and again, we're talking fragments that are 50 to 200 base pairs in length. On the right, you see the prenatal diagnosis. That has just been a huge implication of this field. Universal screening. We've moved away, women having to wait till they're 35 to be at a high risk and moving into amniotic fluids and chorionic villi sampling. Now, pregnant women in their second trimester screening in that 15 to 17 week stage, they can do non-invasive prenatal testing or screening, looking at that blood sample. And actually, as long as there's an intact placenta, those fetal cells are making their way into the maternal blood and then being able to be investigated for all those genetic abnormalities, trisomy 21, 13, 18, sex chromosome abnormalities, methylation differences. So, and again, even if it's a multiple pregnancy, it can even be teased apart. On the left-hand side are other clinical applications of this cDNA. First of all, organ transplants. Even something like bone marrow transplants, we're able to detect the donor-derived cfDNA. The other three examples, sepsis, myocardial infarction, all these types of things were maybe a little more preliminary, but we're seeing that in these cases, there's a increased release of the cfDNA. Next slide. Moving to liquid biopsy, on the right, you can see the tumor volume, meaning in the centimeters cubed, against the VAF, that is the variant allele frequency. And what you can see that as the tumor volume increases from 3.5 to 100 on the scale, the gray dots are basically any tumor. The LUSC are lung squamous carcinoma, where LUAD is the lung adenocarcinoma. But bottom line is, any type of cancer looked at, the larger the tumor volume, you see an increase in the VAF. On the bottom left-hand side, you can see this pictorially. You can see the 1 centimeter cubed versus 10 centimeter cubed versus 100 centimeter cubed. And you can see that the predicted VAF is increasing as the volume increases. I want you to focus at that 10 centimeters square because the VAF is at 0.1%. And we commented, this is around the sensitivity we're trying to aim for. We're at 0.4% VAF. And if you look there, look at the number of malignant cells we're discussing, 302 million malignant cells. So we need a large population of tumor cells, enough to generate the cfDNA, which then will have the tumor DNA. So we need high burden disease. That's why currently we're looking at late cancer stages where it is metastatic. But of course, the field in the future is definitely keeping a keen eye on using this technology for early detection. And but it's just not there yet. Next slide, next slide. So just to put some of this into context, let's just look at a couple of cases. If we had a non-small cell lung carcinoma, and most places would have tissue testing being done, and possibly you identify an EGFR L858R mutation, common mutation in exon 21, known to be oncogenic. You would treat that patient with a tyrosine kinase inhibitor, and there's first, second, third generation inhibitors you could be using. But over time, those patients progress. And again, now you're suspecting resistance. And maybe you're starting to wonder, has the genetic profile, rather than this EGFR L858R, is there something else? You may even be thinking, we've mentioned the EGFR T790M, that's a common mutation. But if the patient possibly is too frail, or you can't get in to get that tissue biopsy, you have the option nowadays to do the liquid biopsy, looking at the blood and taking the plasma. Well, to your surprise, you maybe find a MET amplification. It's not that EGFR T790M, but that MET amplification is huge because it is NCCN listed as a treatment. There's treatment for that. So what is wonderful is that using the tissue initially, but once you saw the progression with the liquid biopsy, it's altering your treatment. And again, NCCN approved. Next slide. Next one is breast cancer. We talk about HER2 negative and hormone receptor positive. Possibly you've even done your testing on your BRCA1 and BRCA2. And now you have the issue with the bone metastases. I just saw a message about volume. Are people hearing me? Okay. So again, maybe the progression here is the bone metastases. And we just mentioned previously the difficulty in obtaining DNA analysis from these bone, once it's spreading to the bone. Well, how can you capture that metastasis? Well, now moving to the liquid biopsy, again, looking at the blood in the plasma, you're finding the tumor cells. And in this situation, you find a PIK3CA with a very known mutation, again, known to be oncogenic, with PIK3 inhibitors, again, this time that are FDA approved. So again, you can alter the patient's treatment based on the analysis of the ctDNA. Next slide. Further example, we're looking at in colon cancer. Again, tissue is done. In this time, you've got a KRAS wild type mutation. But remember, KRAS encodes for upstream activators of the proto-oncogene MAPP13 kinase pathway. And actually in colon cancer, 40% of the time you do see a KRAS mutation. So you may put this patient on an anti-EGFR therapy. And again, that is FDA approved. So you've done your due diligence, but now you get a progression. You see this patient not responding. So again, you're wondering about what is the clinical genetic profile of that tumor. you move to your liquid biopsy, you do your blood sample, and you identify that it's the microsatellite instability high. With our test, we're looking at 21 loci that are very stable. And when we start looking and see any instability in the DNA, we then start to question. We know that in colorectal cancer, about 15% of them are MSI high, of which those 15%, 3 of them are known to be hereditary, which is Lynch syndrome. So when we see that MSI high, we immediately want to sequence the mismatch repair genes. Those 7 mismatch repair genes, MLH1, MLH3, MSH2, MSH3, MSH6, PMS1, PMS2, and we may even have to move into methylation studies in the MLH1. But we would be looking that way in case it was hereditary or Lynch syndrome. But knowing that we have the MSI high, we also will be considering immune technology, because a lot of cancer cells, they actually hide from our immune system. But when we have microsatellite instability and we have high, these cells are actually easily recognized and can be killed. And there are 3, I'm aware of 3 FDA approved drugs. Some use after chemo, some you don't have to use chemo. So again, depending on what your patient that you're dealing with and what options you have available to you, you can now move to your precision medicine. So going to the next slide, we're really using liquid biopsy. We're empowering our patients, the institutes, to make informed precision medicine decisions. Why? Because we're actually finding these somatic mutations. We're not relying on single gene, we're relying on that next generation sequencing. And again, tissue biopsy is very precise on that tissue, but the liquid biopsy is doing a whole scan on the body because the blood is derived and any tumor in the body will be depositing its tumor cells into the plasma. We have a connection with your lab. We're clinically validated tests. Our lab in particular is CAP, DAP, CLIA accredited. So you're getting high quality and standard of care, which we're bringing and offering to your local lab. And how this is being done with tissue and liquid biopsies at next generation level, and that it's complementary to your tissue results as well, but as all guidelines, CAP, the International Association of the Study of Lung Cancer, associated medical professions, the guidelines are clearly indicating next generation sequencing is preferred over single gene, and the international community is even going as far as that liquid biopsy by NGS is actually the acceptable primary approach. So it's an exciting time to be here as a company, on the medical teams, as a patient. We just want to make sure everyone has ability to precision medicine. Anna.
Thank you, Brenda, so much. This was great. So I hope this was useful to you all. And so we now have some time for questions. So we'll happily take any questions that you may have.
I think that there are no questions. So maybe we can just stop here.
Sure, absolutely. Thank you so much. So should you have any questions after this webinar, by all means, please reach out to our partners at Laboratorios Rosalind, and we will be happy to help addressing those questions. So we work very closely with our partners, and we want to make sure that the services they provide meet all the oncologists' expectations. Thank you, everyone.
Thank you so much. Bye. Bye.